Hey, James. Good afternoon, everyone. Good afternoon, Dr. McDonald. I'm so excited to be sharing this ground session with you all to just talk about how we can improve the health of children through policy interventions. What I'll basically be doing would be to walk you through some of the projects I got to work on when I was with the American Academy of Pediatrics in Washington, D.C. just this spring. I was there from April 27th till May 25th. And being the place where I used to live and work before, it was a very nice opportunity to go back there and contribute to wider health policy issues, and I'll be sharing some of those with you today. My name is Ifelayo Ojo. I'm a pediatric resident, second year, and I am here at the University of Minnesota. I don't have any financial relationships to disclose. I really don't own any stocks. I'm not going to be discussing any off-label use of any investigational drug in my presentation. The objectives of this presentation is to help us wrap our minds around the social determinants of health and the impact of these social determinants on child health outcomes. I'm sure many of us are aware of these issues already, but I'll just give us a bit of a background on it because it's a good lead up to the issues I got to work on with the AAP in DC. The other thing is to help us recognize opportunities for child health advocacy in our pediatric residency training and as pediatricians, subspecialists in various fields. And I would also attempt to describe how pediatricians and pediatric trainees can work with the American Academy of Pediatrics to influence health policy both nationally and internationally. I feel like pediatricians are just naturally advocates because we work with very vulnerable people. They are children, they don't have any political power, they cannot vote, and they don't determine what happens to them many times. The fact that we get to work with children is both a privilege and a responsibility for us. And this quote by Thomas Edison is one that my elder brother shared with me sometime about 10 years ago. I know Thomas Edison said it about 100 years ago or something, but he said the doctor of the future will give no medicine, but will interest his patients in the care of the human frame, in a proper diet, and in the cause and prevention of disease. And I felt, I want to be that doctor of the future. And that led me to go study public health at Johns Hopkins in Baltimore from 2008 to 2009. I got to meet many people during my public health training, though, that incorporated clinical work and public health into their practice. And I felt, yeah, I used to enjoy clinical work. Now I want to work on public health issues and protect health, save lives, millions at a time. But that one-on-one interaction with patients and their families, you don't get that in a lot of public health practice, especially at the level at which we get to work. If you have graduate training, you don't get to deliver services like giving vaccines or doing home visits and stuff like that. So I decided that my journey would lead me back into residency training, and pediatrics here was an ideal choice for me because of the kind of program we have here and the opportunities that exist for residents to contribute to wider health policy issues and also global health opportunities to be able to help children all over the world. And that's the kind of thing I want to do with my practice. So just to give a sense of some of the social determinants of health, which I'm sure we all have experienced and are aware of, the physical environment is a big part of that, and part of my presentation would talk about some of the policy interventions that can be done to improve the physical environment, like air and water quality, transportation networks, and also looking at the social environment and the impact of things like family structures, the education level of a parent in the home, usually the mother, or crime and violence within a community, exposures that children have to adverse childhood experiences. All of these things play a large role in who they become and their health status later in life. The other aspect of the social determinants is the economic empowerment and the environment that a child grows in terms of their socio-economic indices of their parents and their immediate community. It's been shown very widely in many studies that just living in one zip code versus another affects the life expectancy of individuals. So all of these things play into the kind of lifestyle and behaviors that people adopt. We know that you tend to be a function of the people you surround yourself with, your own genetic makeup, and the lifestyle that children or youth tend to adopt is mostly those that their parents show to them or their environments. We see some kids getting involved with tobacco use. The e-cigarettes issue was something that was a hot topic when I was in DC because it seems to be penetrating younger and younger children, and the market is not as regulated as the standard cigarettes. So one of the things I mentioned, which has been shown in various studies, is the fact that the educational level of the mother affects how the children get to live. In this case, infant mortality rates was measured as a percentage or as a function of maternal education. Mothers that had a secondary education or higher are the ones that they represented by the lower edge of the bars, and then mothers that had no education are the ones at the upper limit of this bar. And what I would like to call your attention to is that the line is not equal between those that have no education versus those that have had a secondary education or higher, which shows us, and you would see that most of those lines are actually skewed in the direction of those that have no education, showing that the mothers that had less education or no education at all were more likely to lose their kids, which is really, really sad. I picked this graph from the World Health Organization reports where they studied the social determinants of health, and we're trying to talk about how to close the gap within a generation by improving all the factors that play into childhood mortality. And I'm sure we all have heard about the Barker hypothesis, which was based on his study of ischemic heart disease in Europe and outcomes in terms of chronic health conditions like hypertension, and how the environment in which a child is actually conceived tends to play into who they become and their tendency to have adult onset chronic heart conditions. And some of this is defined by epigenetics, the changes that happen to the person without a genetic change. Just the way the gene expression happens is different because of the kind of environment that they've been exposed to. So, talking about the federal affairs internship that I got to do, it was at the Federal Advocacy Office of the American Academy of Pediatrics in Washington, D.C., because Washington, D.C. is where the laws in this country are mostly formulated at the federal level. And of course, each state has their own lawmakers and Capitol Hills and all that. And I got to learn a whole lot more about what the process entails for an issue to become a law and how rigorous this process is. The issues that are discussed or brought to the attention of, let's say, for instance, the Senate is discussed within the Senate, and then they assign it to a committee. The committee would hold hearings on these issues, and then decide if they want to report it to the floor of the Senate for the wider group to debate. At each of these stages, they invite experts like you and I. In one of the cases that I would be discussing, you would see how a doctor gets to lend their voice to issues that become law in the land. But when at the end of the Senate's conversations and hearings and debates and votes, if the issue is one that is thought to be valid and the representative majority votes for it, then they would pass it on to the president for signing, and he could either sign it or veto it. And that's usually, most times, because of the rigorous process that has been involved in making this law, most laws are passed at the level of the presidency, except when there's something controversial going on. So as part of this internship, I got to attend some of those sessions of Congress, the hearings and briefings. You also get to research topics and areas of interest to you, and you can meet with an elected official, and I met with someone whom you'll see at the end of the presentation, so you can hold your breath. Sorry, don't, because this is still long. We're going to be, some of the projects I worked on were the idea of how to reduce the reliance on foster care. It was something I had actually not given a lot of thought to before I went to DC, and I realized how big an issue this was when I was there. The other topic I got to work on was reforming the Toxic Substances Control Act, which some people call TSCA. It's been around for very many years, and there have been attempts to reform it, but because of the very heavy opinions on the side of the industry and on the side of individuals who are trying to protect health, it's been very difficult to come to a consensus. And I got to listen to one of the hearings in the Senate committee. Another issue that I worked on was the idea of how to end preventable maternal and child health, ending preventable and maternal child deaths globally. We're not trying to end the health of anybody. The goal is actually to get rid of deaths and improve health. So talking about what I saw during, or what I know of foster care and my experience with that, the foster care system is meant to be a temporary haven for children who cannot live safely in their own home for a period of time. The goal is always to get the children back to their biological families when the issues that made their home unsafe has been taken care of. Kins, sometimes grandparents, uncles and aunties that have been involved with these children's lives, are sometimes happy to take the responsibility to take care of some of the children that would otherwise be in the traditional foster care system. And group homes are sometimes used as a bridging point for children with specific behavioral or mental health challenges. And group homes really should not be a place where a child would spend all of their lives, because an institution is not a place for a child to grow up. Children belong in families, and they should live with people who love them and can care for them one-on-one. And I'll tell you a story of one of the ladies that spoke at a Senate briefing who had been involved with the group home system. I got really interested in the role of kinship care instead of putting children in the traditional foster care system, because of a presentation that was made and the data that was provided by, and personal stories, of course, of people that had provided kinship care or had been involved as recipients of kinship care, and grandparents that had also provided this care to their family members. But the interesting thing was that 7 out of 10 of the children involved with the kinship care system were able to achieve early stability. And early stability basically means that this child is able to stay in a home for longer than 90 days, gets to start school, and becomes a part of a community instead of moving from home to home before finally settling in one place, which sadly happens in many cases of foster care because of various reasons. The caregivers that are involved with kinship care are mostly grandparents. Some of them are retired folks who didn't expect to receive this responsibility in their latter years, but their children are involved with drugs, or they've gotten into jail, or some other thing happening with a child. The grandparent sometimes offers to take care of the children. Something very important to note about the kinship care system is that they need a lot of support for them to be successful. It's easy to assume that if you place a child with a member of their family who cares for them, they're just going to do well, they're going to thrive. But studies have shown that many times the caregivers are more prone to depression and mental health problems. And some of that can be due to maybe their age or the fact that this is a shock to them at the time at which they're receiving the children. So they need support and ongoing review of what's going on in the system. And so the next thing I'm going to do is to share 3 stories with you. Those 3 stories, as you listen to them or watch it, I want you to think about what your role would be as a pediatrician in these children's lives, because it's like, oh, foster care, I never sent children to foster care, you might think, or I don't even know anybody in the foster care system, but maybe you actually want to get more involved than you currently are doing. So as you watch the story and as I tell the other 2 stories, think about that, and then we would get some feedback. So this is Sunny. She is from Hennepin County, and her story is going to play very soon.
Thank you for listening to The People Station. I am Sonny, sitting in for Miss Candace for your middays. Foster care has been a blessing to me in so many different ways. I stand here today with no regrets about foster care whatsoever. Being in foster care has made me appreciate my family. I love my family dearly. I come from a 2-parent home. I have an older brother, a younger sister. I had a very good childhood. Some things happened with my father where he had to be deported back to Nigeria. That was when I was 8. And I believe it just took its toll on her. My mom has had other things that have happened in her life, and I believe it came back in the form of mental illness. That's how I got into foster care. Her mental illness, it was just too much.
They called me and asked me if I would take her. I said yes.
When I first came there, I kept calling her Margaret. She was like, oh my God, don't call me Margaret. I called her Granny, and it stuck. Yeah, to this day, me and Granny, that's my Granny.
Oh, I liked her, but see, I like kids.
Granny provided a sense of stability, a place of comfort, a place of love.
Here, these kids are my kids. You know, I mean, I've had the county say to me, these are not your kids. And my response is, oh yeah, they're my kids.
She definitely had a loving home, and she provided a place where I could feel safe, a place where I was allowed to be human.
Be a parent and be in their corner and on their team at all times.
Change a life. Change a life. If you have the heart space, for lack of a better word, if you have the heart space, I know my life would be different if I didn't have Granny.
So that's Sunny's story. The next, I'm sorry about that. The next story I'm going to tell you is about Lexi. Lexi was is a young lady I met in DC. She was about 22 when she came to witness at a hearing on group homes and the effects that this could have on a child. Lexi was, I think, about 12, 13 years old when she was placed in her first foster family. She was originally with her family members, our uncle and aunts and their children, and they were willing to keep her, adopt her, and take care of her in their home, but they were not approved by the county because they did not have enough rooms, even though they were willing to make things work. I think there's some rules about the number of rooms you need to have, the number of beds that need to be available in the home, and some of these rules are not flexible to adapt to people's family situations. So she eventually had to move to a foster care home and moved from home to home, never really achieving full stability with any of these families. And then at age 17, everybody was done with her, and they decided they were just going to place her in a group home. Felt like she had too much anxiety and depression. She was too old to go into a home. She was getting close to college age anyway, so she was placed in a group home. She described the environment as being very torturous to her in terms of her emotional health. She had workers that worked there, but they were not allowed to show any emotions to them. She said they were not allowed to give hugs or to tell them they loved them, and some of them actually told them, we're doing this just because of the money, and we're being poorly paid, so we're not going to just have you behave anyhow and things like that. She felt she was being penalized because she had abusive parents, and she was suffering for what her parents had done wrong. She said also that she was given medications for every emotion she felt and did not receive any form of therapy for the trauma that she had encountered as a child. Instead, she felt like things were being done to palliate her feelings and her emotions, and she could not express herself. Another person that gave a testimony at this hearing was a man who had adopted a child from a group home, and he spoke glowingly about how the group home had helped him and his son adjust to each other and helped his son to be successful, because they offered therapy sessions for him with his then 8-year-old son. And as he showed and poured love into this child, he began to see him blossom and was able to take this child home after about a year in the group home. And he's doing very well now. At the time he got in there, he could only read at a first grade level, even though he was in third grade, and was just very, very poorly behaved. But by the end of the time, he started doing well and was able to is still a son in this man's home. So that's about group homes. And then my patient, whom I met just about 3 weeks ago, she's a 17-month-old, very bright young girl. She can speak in full sentences at 17 months. She was just a happy kid, but she had been involved in a motor vehicle crash when her mother, who was high on PCP at the time, ran into several vehicles at about 70 miles an hour on the city roads, and the little girl fractured her tibia and fibula in the process. It was determined that her mother was unable to provide safe care to her, and so the county decided we needed to place her on a 72-hour police hold, which I'm sure many of you have encountered, especially if you worked at Hennepin County Medical Center. And the hold was so that they could find a safe placement for this little girl. And when we had her, we also noticed that she was not up to date with her vaccines, had missed several well child checks. We spoke to the mother about that, and mother said she had concerns about vaccines. That was why she had not continued with the vaccinations beyond the initial set. The other circumstances surrounding the mother were that she also had suffered some head injury in the process of this accident, and even though she was remorseful, didn't seem eager to take the next steps that would be involved in helping our child. So like I said, I wanted you all to give me thoughts on what you think a pediatrician can do in any of these situations, and how we can play a role in the lives of these children, and then I'll tell you what we did, especially with KH. Do we have any thoughts?
I mean, I think one thing is. Sorry, I think one thing as a primary care physician is being a source of stability for the family. You know, if you have a temporary foster care who comes in, you don't know what their stability is going to be like in the child's life or what's going to happen with the mother. And serving as someone who knew the child and will continue to know the child and emphasizing that to both the temporary foster parents and to the mother, I think can be helpful. And like you were saying, foster parents need support themselves. And so, you know, being somebody who can check in regularly, inviting them back for more frequent visits, to look for consequences of, you know, social, emotional health from being involved in this situation. I think that's one way.
Thank you. All the way at the back. It's actually as if Ellen read my slide. You would see it in 2 minutes.
I think there are two things that like a private provider can do. Number one is counseling, like just give more information to parents. And number two, and I think this is the best maybe we can do, is connect them to resources. So get like social resources, everything that we can get as far as the resources for the family to be helped.
Thank you. Any other thoughts? All right, those were very, very good interventions, and I feel like you just mirrored the exact things that I had on my slide. The one thing that we tried to do for KH was to talk to the county social worker to ask if they were exploring opportunities to place her with a cane and what that would look like. And what we were told was that the process is very long to get someone approved if they have not been through the screening process yet. And so they could not expedite that in Minnesota beyond about a week. In some of the states, I think in DC specifically, they have an expedited process for screening family members so that they can place these children early and quickly with them while working on other aspects of the paperwork. So the idea of preparing them for transition to home, speaking with the foster family once they've been identified, and helping them to get to know the child, because we might have known these children maybe for 2-3 days and sometimes for a whole week or more at times. And so we play a role in helping this family get to know who is coming into their home. And of course, we're going to be emphasizing the positives, but not being shy to state the negative aspects of that we might have observed with these children, and offering close follow-up both for the child and the temporary placement or permanent placement, as the case may be. As I think shortly after discharge to a foster home, we want to review how things are going within 3 to 5 days, if possible, and also to stay involved with the process of what's going on with the biological family, what's going to happen eventually, because we can serve as advocates along the way, and you might end up being called to a court hearing if things go in that direction, and being willing to spend our time doing that because we think that might be helpful for this child, or maybe the idea is you're going to the hearing to say this should not be. It's based on what the case is. So moving on, not very smoothly, into the next subject I got to work on is environmental health, one of the social determinants of health that I mentioned earlier on. That the idea of environmental health is to prevent disease and harm that could result from physical, chemical, biological factors in the environment. And a big part of this is air pollution, which is responsible as a contributing factor to about 1 in every 8 deaths. That's a very big number if we think about it. It plays a role in pulmonary diseases, in cardiovascular conditions, in GI issues. It's just such a big deal. And babies and children are very vulnerable to environmental health issues. Some of the reasons for this are that they have higher exposures compared to their body weight because they're really small and you just put a little chemical in them and it's like a toxic dose. The other issue is that they are less aware of risks in their environment, so they just grab things and put into their mouth. They just want to taste everything, literally. And so they could get into lead paints, they could get into mercury or things that are just hanging around. There are also windows of susceptibility that occur in early childhood and in intrauterine life that make children more vulnerable to suffering birth defects or having poor neurodevelopmental outcomes just because their developing organs are in need of good nutrients and materials and not toxic things that could happen. And some of these changes can result in a different functionality for these kids, which in turn plays out to their ability to be socioeconomically capable of earning a good income, taking care of their own children if they have some, or their ability to even comprehend health material and be able to take charge of their own health. So the Toxic Substances Control Act is the U.S. version of the Chemical Control Act that tries to limit the exposure of individuals in the U.S. to substances that could be harmful to their health. It was my very first day in the DC office. Somebody had just given me an orientation about how the laws are made in the U.S., and then they told me, well, there's a hearing this afternoon, committee hearing on the Toxic Substances Act. Do you want to listen to this and give us, take notes and let us know how the voting went? And I was like, oh yeah, sure. But good thing I got to listen to this online and I wasn't there in person because the Senate committee hearings are usually broadcasted live, as I believe this is being broadcasted. It's actually scary to think that some people are listening to me somewhere, maybe. Hello. The idea was to have people share their opinions on the topic and then make votes. It was like watching a soap opera, literally, to watch this debate happen because there were very strong opinions in the room. They quoted lots of doctors. There were no doctors in the room at this time. This was a second hearing and they were going to vote. But the idea that the health effects and the issues that doctors addressed were the ones that people brought up to support their arguments for why this law needed to be reformed and needed to be changed in different directions. And then there were people that represented the industry in their way of saying, no, we need to make the laws as light as possible and not make things too difficult for innovation and progress. And the other issue is the fact that the EPA does the federal regulation and then states do their own regulation, which sometimes is far ahead of what the EPA has come up with. And there was that balance of federal versus states that was also playing into the debates that I got to listen to. This law is still not fully passed. It's been reported out of Senate now, and the next thing is for the House to agree on it. And if both agree, even though they have two different versions of the law, so that's going to be very difficult, they would reconcile their differences and then pass it on to the president for signature at some point in the near future, hopefully, because I feel like this law is an important one, maybe not necessarily in the current form, but what exists now needs to change, and that's where everybody agrees. But what change needs to happen is something that is being debated still. Some of the hazards that happen in developing countries are illustrated on this video. I'm just going to show a little bit of it because we're running short on time, but I just wanted to have you see this.
From cars to clothes and electronics, advances in technology have allowed companies to manufacture products wherever in the world it's cheapest to do so. It's called globalization. For people in Europe and the USA, it's brought prices down. And for Bangladesh, it's meant massive industrial growth. But environmentally, it's often been a disaster. Coming up, we travel to Bangladesh's slums to discover just how polluting the textiles industry can be and why they pollute. we ask what different governments are doing to get the industry to clean up its act. And in the UK, we find out why going green is saving Axminster carpets a fortune.
When I asked the industrialist, the garment industry owner or the fabrics dyeing owner, so why you don't set up EDP? They say there's a big competition in the international market. They always ask for cheap rate. So if we set up ETP, we won't able to provide them cheap clothes. Then we'll lose our money. We'll lose our business. They will go to the other country. That's why we don't set up EDP and we are polluting the environment.
Keeping textile factories running requires vast amounts of energy and resources. In Bangladesh, the industry is dominated by cotton, and turning each ton of raw cotton into finished fabric uses about 65,000 kilowatt hours of power and takes 250 tons of water. It's no surprise that almost 3/4 of the water is used for what are called wet processes, things like washing, bleaching and dyeing. Companies are attracted to Bangladesh because of its low tax rates. That's good for them, but it means the government has limited funds to control pollution. Most of Bangladesh's energy is produced by gas and coal-fired power stations, and that means almost all the electricity used in the factories adds to pollution and CO2 emissions. When it comes to water, Bangladesh might be one of the wettest countries in the world, but a lack of funds means the supply network is run down. Factories often get priority over people for water, and as the textiles industry uses so much water, large numbers of people don't have access to supplies at home.
So that's just an illustration of some of the things that happen in developing countries as a result of globalization, which in itself is not a bad thing. I think during the course of my sojourn in the World Bank, I got to learn a lot about economics and the way things play out for countries and how the policies that are formed in many developing countries, which are targeted at attracting investment, sometimes actually end up being problematic for them because they either do not put in safety valves to prevent hazards that would occur to the environment. An example is in Nigeria, where we have so much oil, and the waters in the Niger Delta region of the country are terribly polluted. There's a lot of birth defects and cancers happening in the children from that area of the country. The food supply is messed up because there's just a very, very lackadaisical attitude on the part of the oil companies in terms for their environmental stewardship. And this also plays into diseases like diarrhea, which is one of the leading causes of death for children, and then pneumonia because of the gas flaring that occurs, and poor air quality. Diarrhea, pneumonia, malaria, 3 leading causes of death for children, and each of these has an environmental component that plays into it. The next slide talks about the fact that we have a triple burden of disease in developing countries. Many of us have heard about the double burden of disease, infectious diseases, non-communicable diseases, but environmental health issues are becoming bigger and bigger and taking a very major role in causing deaths of children in many parts of the world. Almost 2 million children died from the 3 big diseases I mentioned earlier on in 2013, and most of them were in developing countries. This is a map that shows you the deaths attributable to air pollution in 2008. This is by the WHO, and you can just see on the map, sub-Saharan Africa has a high portion of those deaths, greater than 15 per 100,000 children died as a result of outdoor air pollution. And then this also tries to illustrate the exposure that people have to particulate matter, which plays into pneumonia and lower respiratory tract infections. And you can see a lot of the US is good in terms of the annual mean particulate matter exposure, and then you get into cities in South America, in Asia. A lot of the African cities were not covered in this study, but you look at Europe and you see that things are better there too in terms of exposure to particulate matter. This graph I put up just to show how effective a policy could be when you decide to regulate particulate matter in the environment. This was China. In 1997, they decided to institute a new law that controlled the coal industry. Coal industry generates power for most of China, and they also generate a whole lot of pollution with carbon particles. They decided they did not want the industries that used the older versions of the coal-generating machines, and they were regulating and monitoring how much particulate matter was being given off by different industries. So in the control zones, under 5 infant mortality rate fell significantly by 20% compared to the zones where they just continued with things and life as it was. And the most significant finding was that drop in infant mortality rate was highest in the neonatal period, which is a period of life that is really has been difficult for public health workers and programs to make a difference in, just because it has a whole lot to do with the exposures that the mother has encountered. So if just by reducing the particulate matter in the environment, they were able to have a 20% drop in infant mortality in China, that tells us that we could do a lot more in many developing countries. And so this led me to try to be a part of the solution by writing up a policy or an issue. It's called a resolution for the American Academy of Pediatrics, which would get debated at some point in the near future at, I think, the leadership conference. And the idea is to help international pediatricians recognize environmental health hazards and the diseases that are mediated by the environment, so that they can be better equipped to be advocates, and they can speak on the behalf of children with their policymakers and also have these policies implemented. And the International Pediatric Association currently has a website that has a whole lot of environmental health resources, and if you want access to this website, you can just let me know. I can direct you to it, or you can just Google IPA, International Pediatric Association, and you read some of those materials they have there. Some of them are a little dated, but the information in it is still very valuable, and we can always update the materials. Finally, I have this picture with Senator Franken. I got to get breakfast with him and talked about his work on mental health access for children in schools, which is a very important contribution he has made to the lives of children here in Minnesota, and the current plan by the AAP and other pediatricians in the state to have an integrated system where referrals can happen between schools and pediatric practices, and there's a central system for knowing what's going on in all of these mental health interventions. So finally, I would just say, please speak up for children. Raise your hand up and talk, and feel free to express your opinion on what you know about the things that could affect the health of children outside the 4 walls of our clinics, of our hospitals, because these children depend on us to advocate for them, to help them become the kind of adults and the future of our society that they want to be. So thank you for listening, and I would be happy to have questions or contributions, comments.
Could you talk a little bit about the evidence behind the advantage to placing a child in with family as opposed to into a foster care system?
So this study is led by a group in Philadelphia, in Pennsylvania, I think specifically in Philly. they have done a lot of research into foster care, kinship care, mental health outcomes, stability for the kids, and all of that. And I actually have like 5 papers on it. And the idea was to see what's best for these children and what are the factors that contribute to better social and behavioral outcomes for the children, and then their ability to stay in homes for longer periods, which they found helps them stay in schools for longer period. And then when there's stability in their school environment, they're more likely to do well and all of that. So they have studies published from as far back as 2002, 2003, and then last year did some analysis on what the outcomes are when a caregiver has mental health problems. And so they just, I think, administered a emotional screening tool to caregivers and children, and looked at the children that started out with behavioral problems at the beginning versus children that did not, and then what the baseline for caregivers was, and then later on what happened to them. So it's a whole big area, and I'll be happy to send some of those studies to you. But one thing, the word of caution was that we don't just want to place kids in these families and forget about them because they found more depression in them. And I think right around that time too, I saw on the news that somebody had been placed with a family member who was not screened, and this person was a child offender, and looked like they ended up abusing the child that was placed in their trust. So we want to avoid those kind of situations. They need to go through the vetting process and be approved as being safe for the kids, and then they should be followed up if to be able to support them if things happen. So I hope that helps, and I'll be happy to talk more about it. Any other questions, comments? All right. Thank you all so much, and enjoy the rest of the afternoon.